absent, right? Or decreasing or absent vowel sounds. So really is, I should have pointed out yesterday, when those intestines aren't moving, those vowel sounds are going to be very, very decreased, and then eventually they're going to be absent. So take note of that. Forgot to tell you guys yesterday, and I'll reiterate it again whenever we do our review. All right, so lower GI system. Today we're going to be talking about all kinds of things that you're going to see in your patients who have some type of lower GI tract issue. We got some pretty interesting stuff here. Some things that we don't typically see in clinic, and some things you definitely will. So kind of focusing on the congenital disorders and the inflammatory bowel disease. Inflammatory bowel disease definitely is out there in our military population. You will see that. This first one, this first sprungs, this kind of one of those, typically we don't see this in clinic, but they like to ask it on the pants, and it's good to know because if you ever are dealing with a pediatric patient, if you ever specialize in pediatrics, you may run across this. Well, with this thing, there, at the distal end of our colon, that sigmoid colon, the rectum, we have nerves there, right? Those nerves are supposed to be there. When stool goes into that region, those nerves actually allow that part of the colon to relax, right? In this case, the child doesn't develop nerves there. Those nerves never migrate to that region. So as a result, that distal end of the colon and the rectum stays contracted. It stays contracted. It doesn't relax when stool's trying to come through there. As a result, these children aren't able to pass their stool. So that's one of the things that whenever we have children and they're first born, one of the things they want to make sure is that that child passes their first stool. It's called meconium. If they don't pass that stool within 24 to 48 hours, that tells us that something's wrong with that GI tract. When that stool cannot exit that rectal vault, when it cannot exit the anal canal, what happens is that things start to dilate. Things start to back up, right? So you got this contracted distal end of the colon, the sigmoid colon of the rectum. It's contracted, stool is not coming through because it's so tight. And that colon starts to dilate. It starts to dilate, slowly dilate. When it dilates, it's called a megacolon. And you'll see why in a second when I show you a picture of this. That thing gets really, really big. Like I said, oftentimes we're going to find this as soon as the child is born because we're watching to see if that kid's passing the stool. And if it's not, well then something's going on. We need to figure out why. It's typically due to this. Now the thing with this is that we have this stool that's blocking, it's not able to get out, right? And so that stool is going to kind of sit there. But you're still passing stool, right? Stool is still trying to come down into the colon. So even though you have this kind of large mass blocking the way, that softer stool or that liquid stool can actually make its way through that blockage. And as a result, these kids are going to be, passing this watery looking stool. What can also happen is that this pressure can build up so much that they can have this forceful expulsion of that stool. So they're not pooping, and all of a sudden they just kind of release this big massive load, right? Because all that pressure built up that it finally said, you know what, even though you're not relaxing, I need to escape. And so you can get this kind of explosion of stool coming out. These kids are going to have, think about it, if you have a megacolon, if you have a big colon, right, and I'll show you a picture, like I said a sec, you're going to cause a lot of issues in the abdomen. It's going to start causing difficulty with a lot of pain. When you're trying to eat, it's not going to feel comfortable when that kid's trying to eat. So they're not going to grow because when you have stool in your colon, it actually sends a signal to your brain saying, hey, it's not time to eat, I'm still full, right? So they're going to have failure to thrive, which means they're going to have poor weight gain. They're not going to be gaining weight like they're supposed to. The only way we can fix this is if we surgically resect that portion of the colon that's non-responsive. So they'll go in, they'll take out that diseased part of the colon that doesn't have the nerves, they'll take it out, and then they'll reconnect it to the anus, right? And so now things should start working again once we reconnect it. But it's one of those things that if a kid has this, again, very, very dangerous, serious. Go ahead. Go ahead.
Is there a point, I guess, where there's like no integration where they have to do colostomy bag because they're getting so much?
A colostomy? So they may do a colostomy. Colostomy, you guys know what that is? Yeah. They may do one, but typically they'll reserve that if there's like an infection going on, right? Where they'll actually put that colostomy here, typically on the abdomen. They'll reserve that typically if somebody has infection because they want that to heal. With these guys, they're gonna take out that colon and just anastomose it, so reconnect it. Make sense? So here's that picture of that Hirschsprung's. This picture here in the middle, that's an abdominal CT. You can see how that thing is just super big and dilated, right? The one over here on the right, that's a barium enema or contrast enema. So they actually inject contrast to the rectum, and you can see where that distal end is not, it's staying contracted, but above that it's dilated. And then over here on the very left, this kind of drawing, you can see where you have this kind of large, big stool kind of building up, and the stuff that can only get through is that very, very soft stuff or that liquid stuff. All right, so inflammatory bowel disease. So when we talk about inflammatory bowel disease, it's kind of like COPD in a sense, where there's kind of two things that can represent inflammatory bowel disease. We got Crohn's disease and we got ulcerative colitis. I would say probably most likely, most common thing I've seen at least is Crohn's disease out there, or I'm sorry, ulcerative colitis. But they can appear very similar, especially in the beginning. In the beginning, when somebody first develops this, it can be very, very difficult to differentiate between the two. Most of the time, this is going to occur in our Caucasian population, and like this thing says here, typically it's going to start in the 20s, 30s years old. That's when I've most of the time seen it first develop as well. Typically, there's a family history of it, and then again, the thing with this is that there's inflammation in the GI tract. Depending on which disease we're talking about, depends on where the inflammation is. But in the beginning, it's very, very hard to differentiate. Now, if you give it time, I know this thing here says it's impossible to differentiate. In the beginning, yes. But if you give it time, and you actually let this thing progress and you kind of see what part of the GI tract is affected, then we're able to kind of figure out what's going on here and treat it. Now, there's no cure for irritable bowel disease. We can't cure it, but we can definitely treat it. Oftentimes, when patients have this flare of this disease, we'll give them steroids. We'll give them prednisone typically. We'll give it to them for a few days just to kind of calm down the inflammation. But we only use that for flares. We don't, and you guys will learn this, you don't want to use steroids for a very, very long time. Because if you do, it can cause a lot of issues in the body. Down here it says that it can cause immune suppression and increased risk of infection. Well, definitely so. It can also shut down your body's own cortisol production, which can cause a lot of issues. And we'll talk about that when we get to endo and talk about Cushing's disease. There are other medications out there that we can give that kind of target the immune cells that cause this. They're called immunomodulators. Immunomodulators. Most of the time, we're not starting this. We're getting them over the GI, and then the GI will start them on these medications, and then we'll monitor them. But you will give prednisone often for flares if somebody has an acute flare. Don't worry about like the medication names. Like I'm not going to ask you, how do we treat this or whatnot. I just want you guys to know that there's a difference between treating an acute flare and then trying to keep the patient in remission. All right, so focusing on Crohn's disease. With Crohn's disease, we think about this as a right-side disease, right? When I say right-sided, it typically affects that right side of our GI system, talking about the small bowel, so the terminal ileum. It can also affect the cecum and that ascending colon. That's most common. But with Crohn's disease, it can really affect anywhere in the GI tract. It can affect the stomach, the esophagus, the mouth, the left side of the GI of the colon. But the most common area is that terminal ileum. So I want you to focus on that this is a right-sided disease. If you were to see a question on this, I wouldn't try to trick you and say, I wouldn't give you a left case scenario and then say, this is Crohn's. Think about it as a right-sided disease. When this inflammation starts in this disease, it affects the entire GI tract. When I say it goes, it's called transmural. It goes through the mucosa, the submucosa, the muscularis, and down to cirrhosis. So it goes through the entire wall of that whatever organ is affecting in the GI tract. When that happens, we can sometimes get these things called fistulas, where it's an abnormal connection between an organ and another organ. So if the small bowel is affected, right, we got this transmural inflammation. It's going all the way through the wall of that small bowel. It can actually go into another small bowel that's right next to it and cause this abnormal connection. That's what a fistula is. It can sometimes even go, if that small bowel is next to our bladder, it can actually make a connection to the bladder too. So people can start having like stool in their urine, right? Or they can have gas in their urine. So these abnormal connections, because it's going through the entire wall of that organ, it can make a connection with another organ. So that's with this transmural inflammation, that's what we worry about. Now, this is kind of unique to Crohn's disease that you can also have what are called skip lesions. So when you have this inflammation, it's not like it kind of spreads out in this kind of uniform way. It can cause inflammation here, it can cause inflammation here, it can cause inflammation here. So you'll have these patches of inflammation, right, between normal areas of mucosa. So that's what a skip lesion is. And then with cobblestoning, so because it's causing this transmural inflammation, because it's affecting the entire wall of that bowel. Go ahead.
Are those skip lesions fairly common, sir?
Yep.
Like, did you say that's like pathognomonic?
Yep.
Or is
Yeah.
that more of a-
It's pathognomonic, yes. So skip lesions are definitely associated with this. With cobblestoning, because you have this transmural inflammation, right? Because it's going all the way through the bowel, you can get these fissures. You can get these kind of crevices. And if you get these crevices and they interconnect, you can get these patches of normal mucosa between these crevices. So it looks like cobblestone. It looks like you got this divot, and then you got normal mucosa and this divot and this normal mucosa. So it looks like if you think about a cobblestone type of road, you can actually see that on when you do a colonoscopy on these patients or endoscopy. Let's see. Now it says here, early symptoms are not specific and diagnosis is delayed. That's true. When somebody comes in, it's not like you have inflammation all the time. You get these bouts of inflammation, right? And so somebody may come in and they may have diarrhea and abdominal pain, and we're thinking, how long have you had this? Oh, it's only been a few days or maybe a few weeks. We're thinking like gastroenteritis, right? We're not necessarily thinking irritable bowel disease or Crohn's disease. And then symptoms get better, and they go for a few months without any symptoms, or maybe a year or so, and then it comes back. Over time, it's going to start to increase as this thing kind of progresses, but we may not know, we may not catch it initially if we're not thinking about it. We're not asking those questions, or we're not asking family history. And it's not like we can go and, we're not going to see these skip lesions. We can't do that. We can't see cobblestoning until we send this patient off to GI and they evaluate that. So this often delays the diagnosis because they're going to have these bouts of normalcy and then flare and then normalcy, and so it can cause a delay. And think about it, the small bowel, its job is to help with absorption. Its job is to help with absorption. If we cause inflammation to that small bowel, we're not absorbing well. So we may have malabsorption, we may have vitamin deficiencies, anemia, if there's bleeding going on. Now, with the bleeding, let me can this have bleeding? Can you have blood in the stool with this? Can you have anemia with this? Absolutely you can. But I don't want you to associate this so much with bleeding. With ulcerative colitis, that definitely is going to cause bleeding. This one's hit or miss. The patient may have blood in their stool or they may not. It depends on where that inflammation is at. Because although it can happen, we don't typically associate blood in the stool with this one, but it can. And like I said, it can affect the entire GI system, so it's very common for these folks to get canker sores too. So a patient comes in, and patients will come in for canker sores. Is it due to just a normal canker sore that people get, or is it due to Crohn's disease? That's where you ask that history. That's where you just don't try to blow them off and say, oh, they get better. Like ask, are you having any GI issues? Are you having any abdominal pain, diarrhea, family history? So you want to make sure that you're kind of investigating that a little bit further. Now, switching gears, ulcerative colitis, still inflammatory bowel disease, right? But this one is more left-sided. And the thing with this one is that it only stays in the colon. It doesn't go to the small bowel. It doesn't go to our mouth. It only stays in the colon. It starts in the rectum, and then it starts to spread proximally. It starts to spread uniformly throughout the colon. Now, how far it goes to the colon, it just depends on the severity. Most of the time, it will stop at that descending colon, maybe the transverse colon. But can it affect the entire colon? It can. But it doesn't affect other parts of the GI tract. It's going to stay in the colon. Now, with this one, you don't get that transmural inflammation. It only stays at the mucosal level, that very top of the intestinal wall. Because of that, we're not worried about the fistula so much with this because it's not going all the way through. But because there's widespread inflammation, when the GI doc goes in and does a colonoscopy, that mucosa is going to look like sandpaper, right? It's going to look red, it's going to look grainy, it's going to look inflamed because that mucosa layer is what's being impacted. And because right below that mucosa we have our blood vessels, we have capillaries, right? This thing bleeds a lot. So when somebody's passing the stool and they're having a bout of ulcerative colitis, and that stool's passing through that mucosa, it's going to cause that stuff to slough off, and then that's where you're going to see that bright red blood with these patients. They're going to come in, they're going to say, I'm having this diarrhea and it's bloody. So associate ulcerative colitis with bloody diarrhea because that's definitely very common with this. They can also get these pseudopolyps. So I told you that with ulcerative colitis, it spreads uniformly, proximally, right? What these pseudopolyps are is that you can get this inflamed tissue, this inflamed mucosa that's surrounding what looks like normal mucosa. You'll have these flares, right? You'll get this inflammation, and then these flares will start to calm down, and then our GI tract, I don't know if you guys remember this. I told you that those cells replace pretty quickly. They're regenerative. We can replace those once they become damaged. You can get this inflammation that's uniform in the colon, but then as it starts to heal, there are these spots that are going to start to look like they're healing a lot faster, so they look normal. So when that happens, you got this inflammation, right? That top layer is breaking down, and then as these other spots start to heal, they look like what are called polyps. And I'll explain what polyps are when we talk about the colon cancer today. Essentially, it's just a outpouching of tissue, right? Think of it as like mucosa that's just kind of pushing upwards, right? So they look like fake polyps. They're called pseudopolyps. It still went through the inflammatory process. It's just that thing is healing, so it looks normal, but it's surrounded by this kind of flatter area of tissue.
What's a real polyp? What is a real polyp?
A real polyp is just mucosa that's outpouching. It can turn into cancer when we talk about colon cancer, but it's just mucosa that's gotten bigger, essentially. Yeah. But same thing with like Crohn's disease. This thing is they're gonna have symptoms, and then they're going to get better and have symptoms. So it can also be a delayed diagnosis with this as well. If you're not thinking about it. This megacolon. So we talked about ileus. We talked about if we have ileus, that if we're not passing, if our gut's inflamed, our GI tract will not have peristalsis. When this happens, in this case, if you have a lot of inflammation in the GI tract, it can actually cause peristalsis or lack of peristalsis. And when that happens, if we're not pushing things out, you can actually get a megacolon with this as well. Now, if this happens quickly, if the valve stops working and this happens quickly, this megacolon can really, really dilate. And if it dilates, it can actually rupture. It's actually called a toxic megacolon when that happens. And if that thing ruptures and you have stool going into your peritoneum, you're going to have peritonitis and it can be deadly. Now, thankfully, it doesn't happen too often, but that's one thing that's associated with this. Not so much with the Crohn's disease. I don't know why, but this one definitely, you do worry about megacolon and that toxic megacolon if it ruptures. So here's that example of kind of the difference between the two. So you can see here, so Crohn's disease, you get these fissures between this mucosa that looks like little cobblestones, right? This is like a kind of live example of that. And then these pseudopolyps here, you got this inflammation, kind of bringing down that layer of normal mucosa. Then you got these other areas of mucosa that are trying to regenerate, so they look like kind of extra tissue kind of poking out. That's a pseudopolyp. It's not a true polyp. Crohn's disease, again, it can affect the entire bowel, but if we think about it typically on the right side, especially that terminal ileum over here, versus ulcerative colitis, this is only going to affect the colon. It's going to spread, it's going to start at the rectum and then kind of spread proximally upwards. And depending on the severity, it could be the entire colon or just part of the colon. All right, so talking about infectious diseases, so Appendicitis. Appendicitis, again, definitely happens out there. With appendicitis, so at our cecum, right, we got our appendix. I don't know what the purpose of the appendix is. I've heard stories of what they think it is. It does nothing but get obstructed. It's useless, I think. When it gets obstructed, when that appendix gets obstructed, think about it. Our GI tract is constantly secreting mucus and fluids, right? It's there to lubricate our GI tract. It's there to kind of keep bacteria going into the wall of the GI tract. When we block that appendix, when we block the flow of that appendix, which also secretes mucus, we cause a trappage. We don't let that flow come out anymore. And a lot of things can cause a blockage. Typically, we think about like stool becoming blocked there. It's called fecalith when it blocks that lumen. When we block it, it's going to distend. It's going to distend that appendix. And when it distends, it's going to start pushing on that appendix wall, right? When we have fluid that can't get out, it's going to start to distend. It's going to keep secreting, and we start to compress the appendix wall, which is going to compress those blood vessels that are supposed to innervate, right? Kind of squeezing it off. Not only that, but you also have bacteria. We normally have bacteria in our GI tract, and if we keep peristalsis, if we keep allowing that to go through its normal tract and exit the body, that's fine. But when it sits there, when that bacteria sits there, it allows it to proliferate. It allows it to keep growing and multiplying. So now we got this blocked appendix that's continuing to secrete mucus. Now we have bacteria in there that can't escape, and they're just proliferating. We got this wall, appendix wall, that's becoming damaged because we're compressing it because of all this fluid that's kind of building up in there. And as a result, that's going to start to cause that wall to become necrotic. We're causing ischemia there, which is going to break down that wall. And as that wall starts to die, it's going to become necrotic, right? Now, when that wall is damaged, when we damage the wall, guess what? Bacteria can now enter that wall. The wall is damaged, so the bacteria that's proliferating can now go into the wall of the appendix. When that happens, our immune cells don't like that, and they start to attack, and they start releasing all their enzymes to try to kill these bacteria. And over time, that's going to further weaken that wall of the appendix. And eventually, if we don't capture this, if we don't, stop this process, that wall is going to rupture. That appendix is going to rupture. And all that, bacteria, all that mucus, all that stuff, all that inflammation that was trapped in the appendix is going to spill into our peritoneum and cause peritonitis. When that happens, very, very serious, very, very, very dangerous. Our body does not like our peritoneum to become infected. This can happen at any age, for sure. I've seen it in young, I've seen it in older people. It's one of those things that can just happen randomly. And the way this kind of presents itself is, so when that appendix is inflamed, right, we got that visceral peritoneum that's surrounding it. When it starts to dilate and become inflamed, it's going to cause that vague abdominal pain. Remember, with visceral pain, patients are going to be like, I don't know, it kind of hurts somewhere, in my abdomen, but I can't really pinpoint it. Most of the time, though, because of where that visceral peritoneum enters our spine, it's around that T10 region. So when patients have inflammation of that visceral peritoneum that's surrounding the appendix, they're going to say they feel that pain around the umbilicus, around the umbilical, or around the belly button. That's very, very classic. Very classic. Once that parietal peritoneum becomes inflamed, once that inflammation kind of spreads and goes to that peritoneum that lines our abdominal wall, that's when that pain is going to shift. Our patients are going to say, actually, it started here, my belly button region, and now I feel it here, right, that right lower quadrant. Because that parietal peritoneum, it has more nerves. It has nerves that are very similar to our skin, so our brain is able to pinpoint where that's at. So classically, it's going to start at the belly button and then spread or change to our right lower quadrant as that inflammation worsens. And that area is called McBurney's point. You guys check it whenever you do physical exam, right? You're pressing that right lower quadrant, and then, hey, the patient has pain there, and then we had to consider that maybe there's appendicitis going on. Because of the inflammation, they're gonna not feel well. They're not gonna want to eat. They're gonna have anorexia, meaning that they're not hungry. They may have nausea and vomiting, and then fever. Again, in the beginning, maybe they won't have a fever, but as that inflammation starts to worsen, that can kick off our systemic inflammatory process and cause these fevers. We'll see an elevated white blood cell count because our immune cells are ramping up to try to fight off whatever's going on with what's causing this infection. Now the way we treat this, if you think somebody has appendicitis, most of the time in the United States they're going to have an appendectomy. They're going to remove that appendix. There have been cases, there are places out there that will actually try to treat this with antibiotics, but if you read the studies, antibiotics can be beneficial, but most of the time, within a year, this is going to reoccur. So definitively, we want to do an appendectomy. Now, if you're out in the field somewhere, if you're deployed somewhere, and somebody has appendicitis, and you can't get them to a surgeon, well, definitely, then yeah, you want to try to do what you can while you have that patient. But if we're here in the States, we're gonna call the surgeon. We're gonna say, hey, I got an appendicitis, and most of the time, we're gonna do an appendectomy to remove that appendix. Here's what I was talking about. Here's kind of an example of what this looks like. So you got your appendix here, obviously, and then you have some type of blockage, right? Typically it's stool. It can be a lot of other things, but the most common thing is stool. This thing blocks it. So now the appendix is still doing what it's supposed to do. It's still releasing its mucus, its fluids. You still have bacteria in there. And as it continues to do that, that pressure is going to build up. It's going to start to compress the wall of the appendix. When it compresses the wall of the appendix, now blood flow can't go anymore, right? We're compressing that area. And as we decrease that blood flow to that wall, it's going to start to become necrotic and die off. Ischemia, necrotic, and then die, right? You got bacteria in here, and as this wall starts to break down, bacteria can now enter that wall. Now we have immune cells coming in there, causing further damage. And then eventually, if we don't remove this appendix, we don't take care of it, this thing can rupture and actually cause all this infectious process to go into our peritoneum and cause peritonitis. And then here's McBurdy's point. So it's right there between that anterior superior iliac spine and then the umbilicus, kind of right there, that third. I will tell you, that's the most common area, but not everybody presents that way. So a pregnant woman, as that uterus kind of pushes up on the organs, it can actually cause that appendix to go up higher, and if she develops an appendicitis, it may not be in that right lower quadrant. Sometimes that appendix can be instead of coming out like this, right, forward, the cecum can actually be bent backwards. So that appendix can be backwards. And I had a patient one time, he came in and saw me, and told me he had back pain. He said he had right back pain. I said, okay, so I did my exam, it was kind of benign, and he had no GI issues, no nausea, no abdominal pain, it was just back pain. So I treated him for back pain. I gave him some NSAIDs, and I told him to do some stretches, some heat and ice. The next day, when I get into the clinic, I get a report that this dude went to the ER because he started developing abdominal pain, and they CT'd his abdomen, and he had retrocecal appendicitis. He had appendicitis, but his appendix was back here, right? And so,
Well, how dare his anatomy?
I know, right? I was like, how could you do that to me? But I was like, oh shoot, I didn't even think about appendicitis. He didn't even cross my mind. So most of the time, it's going to be that right lower quadrant. When I've seen it and I've diagnosed it, it's been that right lower quadrant. But some patients don't always present like we teach you guys. So if somebody has back pain, right lower back pain, think about that. Not for the test, but all right. That'd be a tough question. Okay, so kind of moving on. So Meckel's diverticulum. So Meckel's diverticulum, it's kind of this thing here. The thing that starts this off, right? So when you have an embryo, you got this thing called a vitelline duct. Right? You don't have to know any of this vitelline duct stuff I'm about to tell you. I think it just kind of helps figure out or put together why this happens. This vitelline duct, it connects to the yolk sac. That yolk sac is what first kind of sustains that embryo as it's developing. And then once the placenta takes over, that yolk sac, that vitelline duct, it goes away, it regresses, it breaks down, right? It involutes. When it involutes, like it's supposed to, great, no problem. But sometimes that thing doesn't involute correctly. And as a result, we can kind of get this extra tissue that typically affects the small bowel, the ileum, where you have this kind of outpouching of this tissue that shouldn't be there because it was supposed to break down, but it didn't. So now you got this kind of this thing, this little thing hanging off the ileum, kind of like think of it like the appendix, even though it's not the appendix. Think about it as like a little extra piece of tissue hanging off that ileum, that small valve, right? It has a lumen, it has an opening where stuff can go into. When stuff is passing, when food is passing through the ileum, and you have this mecculus diverticulum, you have this extra outpouching that shouldn't be there, food can actually get trapped in there, or stool can get trapped in there, and it can cause the same process like an appendicitis. It can block it. You have bacteria there. That bacteria can proliferate. You have mucus that's secreting. It can start to distend that wall of that diverticulum, and then perforate as well, right? So we worry about this sometimes, especially in our kids who may look like they have an appendicitis because of where it's at, even though it's not directly at that right lower quadrant, it's close enough to where it may fool us. And if that process is going on in that mecculus diverticulum, when we have that blockage, it may present like an appendicitis, but when we go and we work this up, their appendix is fine, right? Now think about the embryo too. The embryo, that it's still developing. It's still trying to put its pieces together. And so those cells that are in that embryo, they're called pluripotent cells, right? They can transform really into anything. Sometimes, most of the time, it's going to that mecculus diverticulum. Most of the time, it's going to transform into actual small bowel, actual ileum, right? Ileum tissue. But because that embryo those cells are very young and immature, and they have the potential to transform into anything, sometimes that tissue can actually be what's called ectopic tissue, meaning it shouldn't be there. It's not normal tissue that should be there. It can transform into either gastric mucosa or it can transform into pancreatic mucosa. So you got this diverticulum that is actually made up of gastric tissue or pancreatic tissue because those cells are immature and they can transform into that. So you don't know what you got right until you actually go in and remove it. And I'll explain why that's important here in a second. So when we talk about mecculus diverticulum, think about the rules of two. This is a actual thing that is valid, right? The rule of two means that 2% of the population may have this, right? It's going to be within 2 feet of the ileocecal valve, so where that cecum and ileum meet, it's going to be within 2 feet of that, which explains why we may see it in the right lower quadrant or around the right lower quadrant, because that valve is where that appendix is, right? It may consist of 2 types of ectopic tissue, so it can be gastric or pancreatic. Now think about it. If you have gastric tissue in an area where gastric tissue shouldn't be, and that gastric tissue is releasing hydrochloric acid, what's going to happen? It'll start to cause inflammation, breakdown, bleeding. And so you may potentially, instead of having the typical appendix symptoms, a child may come in with just pain. They may have, blood with their stool because that gastric mucosa is not where it's supposed to be. And as it releases that acid, it's going to start breaking down the tissue around it. And then typically presents by 2 years of age, because most of the time when this thing either gets obstructed or if that gastric tissue or pancreatic tissue starts to damage it, we're going to catch it pretty quick. So in order to identify this, there's a couple of different ways. There's something called a Meckel scan, where we inject this kind of radioactive dye into the kid, and then that if there's gastric mucosa, that dye is going to absorb into that mucosa. It doesn't work for the pancreatic. It doesn't work for pancreatic. It only works for the gastric mucosa. So if a kid comes in and they're having abdominal pain and they're having kind of unexplained bleeding, one of the recommendations is to get a Meckel scan where we inject this kid with dye. And if it's a gastric type of ectopic tissue, what you're going to see is you're going to see kind of this lighting up of the stomach, and then you're going to see this lighting up of an area within the abdomen that shouldn't be there because there shouldn't be any gastric mucosa. And then you'll see it kind of go into the bladder because that's where our blood is filtered, and then it kind of winds up in the bladder as well. What can also happen though is if we have obstruction. So we talk about kid who has abdominal pain and unexplained bleeding, but there's no obstruction, right? It's just that mucosa is causing damage. If you actually have an obstruction and it presents like an appendicitis, well then sometimes we'll identify that on CT because, think about it, a kid's coming into the ER, he's got abdominal pain, you go and you check this kid out, and he presents like an appendicitis, you're probably not going to wait for a medical scan. I mean, that's because in your mind, you're like, I got to treat this now because if this thing ruptures, this kid's going to get really, really sick. So we can sometimes identify it on CT. I know they taught you in radiology, we try to avoid CTs in kids, and that's definitely true. The problem with the ultrasound with this is that when you do an ultrasound on this and you're looking for appendicitis, that appendix is going to be normal. It's going to be hard to find that necklace and all that valve. And so, even though we don't want to, we will do a CT on a kid if we think there's an appendicitis and we can't find it. The only way to kind of treat this, especially if it's symptomatic, is remove it, right? Surgically remove it. If you find this on a kid or if you find this in a person and they're not having symptoms, say this person had this their whole life and we didn't catch it, and you randomly do a CT on their abdomen and you see it and they're not having symptoms, then we're gonna leave it alone. We'll educate our patient and say, hey, if you have XYZ, you need to come in and see us. But if you just instantly find it and they're asymptomatic, we probably won't do anything with it. But when they're symptomatic, when they're having symptoms, that's when we'll go in and actually remove it. Okay? So here's that medical skin. So you can see there, kind of that upper part, kind of up at where the stomach would be. That's that gastric mucosa. It's lighting up because that gastric mucosa is absorbing that. It's called technetium. It's absorbing that radioactive substance, and then right in the middle, that's where that necklace is. That's where that diverticulum is. It's going into that tissue that has gastric mucosa there where it shouldn't be. So we kind of see that right in the middle. It's kind of lighting up, and then the very one kind of lighting up at the very end, right here, that's just the bladder, right? That's as our blood filters our kidneys filter our bladder, it's going to end up in our bladder. It doesn't mean that that's gastric mucosa. That's just kind of where things are. But
if you're going to do surgery on anyone, can you elect just go ahead and move the appendix by your area, or is that?
I don't know. I mean, that'd be up to a surgeon. I don't know if you would. I don't know if you'd want to just do that just right off the bat, very systematic, but I know they do it. I know sometimes they'll go in there and say, hey, we can do this, but it just depends on the surgeon and their thought process. All right. Switching gears, so now we're going to talk about colonic diverticulitis. So diverticulitis. So a diverticula is just an outpouching, right? It's an outpouching when it happens in the colon, we call it diverticulosis. So when we have our colon, right? And in between our colonic wall, we have blood vessels. Those blood vessels are kind of weak points of that colon. So if pressure starts to increase in the colon, where those blood vessels perforate, right, where they're supposed to be, because they're there, they cause that weak point. And if the pressure builds up in the colon, it can actually push that colonic mucosa through that blood vessel kind of opening and cause it to come out the other end of the actual muscle itself. So we have this outpouching of colonic mucosa that's pushing through the wall between that weak point in where the blood vessels perforate. So diverticulosis just means that you have a lot of these diverticula. That's very, very common. A lot of your patients are going to have diverticulosis as they get older. Very, very common, right? When that diverticula that's there already becomes obstructed or becomes inflamed, then we call that diverticulitis, and that's not good. Diverticulitis is symptomatic. Patients are going to tell you that they're going to present a certain way, and we'll talk about that here in a sec. But diverticulosis, very, very normal. A lot of people have it, especially as they get older. Diverticulitis is the result of an inflamed diverticula. It's an inflammatory process, typically due to obstruction, which can lead to potential outcomes like perforation and sepsis if it actually perforates all the way through. So what happens here, right? So if you have typically we associate this with chronic constipation or a lifetime of constipation. As that colon is trying to contract and push that stool through, if it can't, it's going to cause a buildup it's going to cause a buildup of pressure in that colon. And when that happens, it can force that mucosa through that weak point of the colonic wall and cause this diverticula, right? Very similar to appendicitis and chylomecals. If it becomes obstructed, if stool gets trapped in there, and that mucosa is still secreting, mucus and fluids, and there's bacteria there, if we don't allow that stuff to escape, it becomes entrapped, that diverticula is going to become swollen, that wall's going to become necrotic, you're going to start inflammation, and so when that inflammation starts, it can potentially become ischemic because we're compressing the wall, so we're not letting blood flow through, and if that happens, then the necrosis can set in, and then the bacteria that are there can go into the wall and cause a very, very similar pathology like appendicitis, where it can actually rupture, becomes weak and it ruptures, and then all that stuff that's trapped in there can go into the peritoneum. If it's just inflamed, right? If there's no perforation, if it's just inflamed, there's no hole in the diverticula, then we call that uncomplicated diverticulitis. The patient will present. They're going to say, "Hey, I'm having left lower quadrant pain." You're going to push on their belly. It's going to be painful. But when that happens and we catch it in time, then we can treat this very easily. We can give them antibiotics. We can kind of make them NPO, so don't feed them. Let that bowel rest. The problem happens is when that diverticulitis actually perforates, when it ruptures. That's where we run that risk of letting all that stuff that's in that diverticula escape into the peritoneum and cause that peritonitis. Now, if it's a microperforation, so if it's a small hole, you have other things within the abdomen that can sometimes seal that off. You have fat there, obviously. The omentum's like, it's crazy. It's very good that we have that thing, because that thing can actually move around, and when it senses inflammation, when it sees inflammation, it can actually go and kind of attack and attach itself to wherever that inflammation is at, to try to help it heal, because there's a lot of immune cells in the omentum. So sometimes sometimes that will kind of stop that perforation from actually letting it spill out to the peritoneum. The problem, so these patients are going to be sick. But they're going to be stable. They're going to have, they may have a fever, but their blood pressure's not dropping because they don't have this massive inflammatory process. They're not going to feel good, but they're not going to feel good, but they're not going to look like they're dying. Now, when that perforation is really big, if that perforation is really large, or for some reason, whatever, that containment didn't work all the way, we weren't able to contain that perforation all the way, we start letting fecal bacteria escape into the peritoneum, that's when these patients are going to be very, very sick. They're going to have generalized peritonitis, meaning that they're anywhere you push on their belly, because that inflammation is now spreading through that peritoneum, they're going to be super sick. They're going to be very, very sick. They're going to look like they're about to die. Their blood pressure is dropping. They're tachycardic. They're having very, very high fevers. And so, either case, if there's any type of complicated diverticulitis, we're going to admit that patient, and depending on the severity, depending on kind of what we do. For the uncomplicated part, we're going to still treat them, but most of the time we won't admit them. We'll just kind of give them antibiotics, watch them for a few hours, typically in the ER, and then they'll be discharged and sent back to you as their PCM to just make sure they're doing well, right? So again, diverticulosis, that's that normal thing that people get. Often you're going to find it on colonoscopy whenever patients are doing their routine colonoscopy. It's not a problem. Somebody has diverticulosis, you don't do anything for it really, except try to educate them on hydration and adding fiber to the food to try to help them not be constipated. When they have diverticulitis, when they have that inflammation going on, that's when we have to treat this. So the reason why it's most of the time felt in the left lower quadrant is because that sigmoid colon, that's actually the narrowest part of the lumen of our colon. And so if you have, and it's also the most distal part of the colon, so think about it. As stool is trying to pass through the colon, water's kind of being sucked out of it, right? So by the time it gets to that sigmoid colon, most of the time, especially if you don't hydrate well and you don't have a high fiber diet, which helps keep water in the stool, when it gets to that point, that thing is rock hard, right? Because they already got all the water sucked out of it. On top of that, it's the most narrowest part of the colon. And so when stool gets there, the colon really, really has to contract and kind of push that all the way through to the rectum and out the anus. That's why this left lower quadrant is the most common site because that's where that diverticulosis most commonly occurs because of that high pressure there. If stool gets blocked in that diverticula, that's when you get the diverticulitis and they're going to have that left lower quadrant pain. Make sense? When they have diverticulitis, they may have a fever, but if the perforation or peritonitis sets in, the fever is going to be a lot higher. They're going to have an elevated white blood cell count because it's an inflammatory process. Sometimes these things can bleed, and so if you do a stool, like a fecal occult, like check for blood in the stool, then you may see blood bleeding. That inflammatory process, when we have inflammation in our gut, it's going to change our bowel habits, so we may have constipation, diarrhea, or just they're not going to be pooping like they normally do. And then because of inflammation in the gut, you can have patients who present with nausea and vomiting. But again, uncomplicated, no perforation, just inflammation, right? We're going to give them, treat them with bowel rest. We're going to give them antibiotics and kind of watch them for a few hours, and then they're good to go. If there's a perforation, or if there's peritonitis, or if they have an abscess, which is essentially, whenever the omentum kind of traps off that perforation, and so it's not actually leaking to the abdomen, but it's just kind of, it's still perforated, but it's not leaking because it's trapped. Or if the fistula forms, we talk about fistula, sometimes this can cause fistulas as well. So we're going to admit them, give them IV antibiotics, and depending on depending on the severity, when I've seen this, most of the time they'll do a colectomy where they actually remove that portion of the perforation. They just can't go and sew that thing back shut. They have to actually remove that segment that's perforated. And that's what I was talking about when somebody asked me earlier. When there's, depending on the severity, sometimes they'll do a colostomy where they'll remove the portion of the colon, it's a colectomy, but there's still, it's still inflamed and there's still inflammation going on. So instead of actually connecting the colon to the rectum, or the colon to the normal piece of colon, they'll move that colon to the abdomen wall, do a colostomy where that stool now comes out of the abdomen to allow that to kind of heal. It just depends on the severity. You guys don't have to worry about that, but the main thing is that you got to admit these people and then let the surgery take care of them and figure out what they want to do with it. Here's what that looks like. So you can see here, normal colonoscopy. You can see there's no holes in the wall. Over here, this looks like just a ton of holes, right? This looks like it kind of goes through here, like it's supposed to go through here, but then you got this hole here, here, here. This is not necessarily diverticulitis, it's diverticulosis. When these holes, when these outpouches become trapped and inflamed, that's when you get that diverticulitis, that inflammation, and that risk of perforation. All right, take a 10-minute break.
I couldn't find my cat. I see it. I was on the bench. So I was just asking him, like, it was still there. I was like, oh, I'm gonna find it. You are very honest. I was just all over. You were all over. I think it was all fucking tired. Yeah, I was everyone was like hanging out off the beach that you like. I don't know, like, food also.
What is something like what is go through that. It's what you I was like, well, I first watched the box. I heard it.
That's Monday, Thursday, Sunday.
And you're from like
Okay. Like Scotch days, I do a shit coffee. He's tired. I'm always, oh, yeah.
I like to watch Ratchet TV. Like girls that fight each other.
for like 2 episodes and like it's stupid. I saw like one of them is now my wife like I didn't watch it with her and I'm like this is
I feel like it was wrong.
the people.
Oh yeah, love. I like love. It makes me cry. Like they're so brutally honest. They're like, it's like 2 minutes in, they're like, this is cool. And I'm like, oh my god. It's like, so, are we gonna so my friend, so I did transition to like, I want to date. Like someone here, I don't mind feeling I'm like, they just want to be. Everyone does it. I think it's so cute. That like, that's really what they want. Because they're so brutally honest. This is why I feel like a lot of people are like, and I didn't know that that was a sign. That's something that was.
Specifically, I'm also very firm believer that spectrum disorders are very overdiagnosed. Like
That's why I
like if you're trying to make a case or something that's just that like just to be able to get
yeah, I feel like that's a nice way to go on.
like
Yeah, we can be on.
overstimulated. Like I don't know your spectrum is how you work.
And it could be a lot of things. It could be maybe even like if I'm looking
Also, that's another thing. Like my sister-in-law, she was like therapy for something, and they were trying to convince me that she has a cat specifically because. Specifically because her that my father-in-law would like come here to like he would get the point off because it was that like around work and stuff. So they were saying, oh, he's all appointment, and because of like one incident where she had a softball game and she yelled at her team. Yeah, so it's like that's like that's
I've never seen one. I've seen like a counselor. You should probably talk about that. So let's go deeper into that. I'm not going to tell you. Here's the truth. Everyone has a lot of like to say like, oh well, this I had a workshop. When you decide that, just like what they do, you don't feel that type of way. Also, I don't believe in like. You could make something out of nothing too.
all things
You could make something out of nothing, but you also could downplay it. So there's just like, it's just so something. That's why I just eat Who do we like to lead? How's the knee? Wes is hard to even do. I did a lot better yesterday.
Yeah, like yesterday was good, which gives me a better feeling about sight that he did something more like that, not like how the reality one. Peaceful.
You know everyone?
No, Hanson is the other the first we had.
How do you not know people they sit in front of us in uniform with their name?
She's like, I don't want class.
I know George.
What's his first name?
Alex. His name is Alex.
Yeah, there you go. Do you want to sit over here? We'll take your back over there.
I don't know.
How dare you?
I don't know his name.
I'm bad at names.
She doesn't know anybody. She only knows my first name.
She doesn't know where she's at.
Our first name. That's it.
She doesn't know who the professors are.
She
They
doesn't.
sit up there with their name and their rank
She
and
be like,
everything.
Lieutenant Colonel Rogers. She's like, who's
I
that?
thought about put the class name. I was like, well, something's wrong. You don't know their name.
They're the easiest one. They have their name on there. She's asking who we should put in the dump tanks. It's in our least favorite, Captain Plains. He did okay yesterday. He wasn't too much. She's just
I don't think
she's
females would
neutral.
really want to get in the dump tank.
Still nominee.
But she's just neutral. What do you have against her?
I'll vote for what the majority wants.
Oh.
What do you guys vote?
Everyone from our semester.
Oh, this semester.
You want to nominate?
He's like, I'm not paying attention.
The
Who you
dump
want
tank.
to nominate for TA Day?
She's trying. That test gets so much harder.
It's just water, guys.
No, she's I'm gonna vote for him. He won't care, you know, he's bald and get it off. He's a good professor, but his tone is so kind of mono.
Yeah, I get lost.
I went and met with Nature Park yesterday. We talked about the exam, and there's the one in class she mentioned. What weeks back? She said there's one more she's thinking about, but she said in terms of the next two tests, to try to do your best on the next one coming up, because I think it's a bit easier than the one on the back end.
What's the reason? Because
So I was like,
here, they got ran to 2 days flip for last year. That's wild.
And I brought them the slides.
The radiology test, you can't be here that day.
oh,
You can't do it this day because it's a virtual day. So we got RAD 2 on Tuesday. Because we're doing school from home this day. RAD 2, 2-day flip.
oh, I didn't know that happened.
That's why everybody needs to crush this one.
Oh my god.
Stress.
Why is that a virtual day?
I don't know.
Oh, that's great. That's great.
Yeah. You might want to, the new one. Have you seen the new?
She's like, I just got my
The new calendar?
Yeah.
No.
The schedule.
I went through the one when they changed the clean skill stuff, but I didn't know it was more than that.
Yeah. So here it is. Yeah. Some code path. Brad.
Yeah, I boxed it out because he can't do this Friday, and this is a virtual day, so he has to do it here, and then we have farm right after.
So all that is already switched around.
Trash.
So I
So
just
that's why she wants everybody to crush the next one, because this one is going to probably get people, because nobody's going to look at this, because everybody has to pass this to go to next semester.
Yeah. Why do they do this? You have all this space? All this space down below?
You got a good buffer though.
Yeah, I put a big X on the test and I drew a big block down here. Do you need a marker? Hey, wait. It's where he's supposed to teach on
Alright,
Tuesday.
guys ready? Alright. So, kind of moving on. So, there are, so with the, kind of sticking with the lower GI tract, there are a couple things that can also occur. So one, especially in children, one of them is called intussusception. Intussusception means that a piece of that small bowel, typically, or it can be other parts of the bowel, but we typically associate with the small bowel, telescopes into the colon, right? So you got the small bowel, you got that, that cecum, that ileocecal valve, and that small bowel can actually be dragged into the colon, right? So it's telescoping in. It's not always just small bowel, but when we think about it, this is what we typically think of, okay? When that happens, and that small bowel is being pulled into that ileocecal valve, into that colon, right? We're compressing it. We're dragging it into the colon and we're compressing it. And now anything that tries to get past it can't, right? It's causing an obstruction in a sense. Not only that, though, you have mesentery, right? Your mesentery is what has all your blood vessels that innervate our bowel. When you drag that small bowel in, you telescope it, you're also pulling in those mesenteries, which are compressing those blood vessels. So as a result, you got this peristalsis that's trying to occur, but it can't because there's a blockage because that small bowel is being pulled in to itself. You got this mesentery that's being compressed as well. These kids are going to have a lot of pain. Typically it happens in children. It can happen in adults. I'll explain that here in a second. But typically we see it in children. So as that peristalsis is trying to take place, these kids are going to have what's called colicky pain. They're going to have this, this contraction of the small bowel. It can't get through. It's causing a lot of cramping pain. And then when that peristalsis stops, whenever it's not pushing anymore, kids are going to be fine. Then a few minutes later, it's going to try to keep pressing again. Kids are going to have pain, so it's called colicky pain. So it comes in waves, this pain. Okay. If we start to decrease that blood flow to that bowel that's telescoping into another part of that bowel, we're causing ischemia. And as we cause ischemia, we're decreasing blood flow and start to necrose. And as a result, that part of that small bowel starts to die, right? When it starts to die, things start sloughing off, you start getting blood. So this is another one of those red current jelly-like, explanations. You get this red current jelly-like stool that can happen as this thing kind of progresses. Now, if we identify it before that happens, we can actually do what's called either an air enema or a contrast enema, where essentially we shoot either air or contrast into the rectum. And if we do that, that can actually push that telescoping that's going into the colon and push it out. So we can re-extend it out that way. That's a very good way to try to kind of get this better quickly when we identify it. So again, most of the time we see this in kids. This can occur in adults, especially if they have colon cancer. So think about colon cancer, right? If we have a mass that's kind of sticking out in the colon, and as peristalsis takes place, right, I think of peristalsis like a snake, right? Like kind of how a snake travels on the floor. It contracts its body to kind of push things along or move around. If you have something in the colon, right, and peristalsis is taking place, and it attaches to that colon, that cancer, that mass, and peristalsis is moving, right? It's trying to, it's compressing and then it's contracting to kind of get that stool moving along. If it gets a piece of that mass, it can actually pull that thing into it. So that's how telescoping can occur in adults. Again, most of the time kids, but sometimes adults, especially if they have colon cancer, something sticking out into the colon and it can actually attach to it, pull it into itself. All right, so with volvulus, so with this one, there's a piece of the bowel that actually twists upon itself. So it twists. Most of the time, it's going to happen in the sigmoid colon because that thing is kind of curvy as it is, and if you have a big piece of stool in there, that can actually kind of make it dangle in a sense and make it twist. And when it twists on itself, what are you doing? You're cutting off blood supply to that thing. So as a result, you do worry about ischemia, necrosis, and pinch perforation. But what happens here is that, when peristalsis stops, right, we start to see gas come out, right? This thing, when you shoot abdominal X-ray, you're gonna see kind of this big coffee bean or kidney bean looking thing that's just full of gas. Gas from what we swallow, but also bacteria are kind of what make the gas in our GI tract as well. So bacteria is in there and it's causing gas, so you get this buildup of gas because this thing is twisting on itself. So it's not moving anymore. When that happens, we need to get them to a surgeon right away so they can make that thing not twist anymore. They can make it straight. Here's what that looks like. So interception, again, telescoping, that valve is going into, typically into the colon. When we think about kids, it's being pulled into it. Versus the volvulus, there's a twisting. And so as a result, when you shoot an abdominal X-ray, you see this kind of big gas bubble, right? It looks like a kidney bean or a coffee bean. Either case, with the barium or with the intussusception, we can try to treat this with a barium enema or air contrast enema, or an air enema. Versus the volvulus, we have to get them to a surgeon. We can't untwist that. The surgeon needs to go in there and actually, undo that. All right, hemorrhoids. Hemorrhoids. You're gonna see hemorrhoids. With hemorrhoids, all this is that at the rectum and at the anal canal, we have blood vessels, right? We have veins called the hemorrhoidal plexus. When we have an increase in pressure in that region, those blood vessels, those veins, they become dilated. A lot of things can cause this. Constipation is a big one. If somebody is sitting on the toilet and they're pushing really, really hard to try to get that stool out, it's going to increase that pressure down in that hemorrhoidal plexus, which can cause those blood vessels to bulge out. Low fiber diet, obviously if you have a low fiber diet, you're having constipation. Pregnancy, so think about it, you got baby down in the uterus, it's compressing all those blood vessels, blood flow is not easily coming back up, and so it causes a lot of pressure down in that hemorrhoidal plexus. Prolonged sitting on the toilet, this is very, very common. When patients come in to see you, you have to ask them about their bowel habits, right? You have to ask them what they're eating, how long they're on the toilet, do they use the phone on the toilet? When they're sitting on the toilet, typically they're on their phone, right, watching whatever. When they're sitting for too long, that can actually increase that pressure. And so we have to educate our patients, hey, you can't poop within 5 minutes, get up off the toilet, don't be on the phone. We just got to educate them and try to get this better, because if they keep doing that thing that's contributing to it, then it's going to be very, very hard to make this go away. So when we talk about hemorrhoids, though, we can talk about them in two kind of aspects: external hemorrhoids and internal hemorrhoids. The way we determine whether a hemorrhoid is external or internal is based off what's called a dentate line. So in the anal canal, you have this line called dentate line that separates the visceral mucosa from the mucosa that's more somatic, right? That's more sensitive. With that external hemorrhoid, this is stuff that you're going to see. Like, you can actually visually see these hemorrhoids whenever you do a rectal exam. These patients are going to have itching. They're going to have burning pain, because think about it. If you have something in there, if you have like a mass at your anus, and your patient is trying to clean that area, they may not get it all because there's something kind of blocking it. So they may have kind of stool left over there, so they may have that itching, or they may try to over clean it. They may they got this mass here. This vein, and they don't like it there, so maybe if I just clean it really, really good, it'll go away. Well, that can cause irritation as well. So your patients are going to come in with, typically it's itching. If that thing is thrown, if there's a blood clot in that, if there's a blood clot in that vein, which again, if blood's not moving, you have hemostasis, you can actually get a blood clot in that hemorrhoid, then it may be painful, because as that thing clots and that pressure builds, it's going to push. It's going to cause a lot of tension and pain, and sometimes they can rupture and bleed, and so sometimes patients will have bleeding with their hemorrhoids. Again, most of the time you're going to see these on visual exam. You can actually see them. With the internal hemorrhoids, because of the mucosa, because it's visceral mucosa, that visceral mucosa is poorly innervated, most of the time your patient's not going to know that they have a hemorrhoid. Instead, what they're going to come in and they're going to say, hey, I have bleeding whenever I poop, right? Whenever I have bowel movement, I have blood in my stool. Now, the hard part about these internal hemorrhoids is that, again, they're not painful, so patients don't know they have this. But when you do your visual inspection, you're not going to see it because it's high up in the anal canal. You can't see that region. When you do your digital rectal exam, your DRE, it's very, very hard to appreciate them. It's very difficult. Unless they're really, really big, or unless they're prolapsing out into that to where you can see it, which can happen, you're not going to know that your patient has this. So, if somebody has painless bleeding, don't assume that it's probably from an internal hemorrhoid. Because if you can't see it, if you can't feel it, even if you can feel it, you're not for sure. If somebody has painless rectal bleeding, do not assume it's a hemorrhoid. You got to work them up. Typically you want to send them to GI so they can do a colonoscopy. You can also do anoscopy where they kind of stick this device in the anus and then they gives them a better picture of kind of what's going on in there. But most of the time they're going to just jump to a colonoscopy because they want to make sure that you don't have colon cancer. And I will tell you, this has happened before. People come in for painless rectal bleeding and they say, oh, but I got a history of hemorrhoids, and people have said, okay, it's probably hemorrhoids, and then guess what? It wasn't hemorrhoids. Especially in your old folks. If somebody comes in and they're old, even if they tell you, yeah, I got hemorrhoids, I just need my whatever medication. If you can't see the hemorrhoid and you don't see active bleeding coming from an external hemorrhoid, do not just send them home with a stool softener or tell them to hydrate. You have to send them to a GI. The worst thing that's going to happen to you is that the GI doc's going to be like, why'd you send them to me? We don't have to treat this. It's a hemorrhoid. Okay, cool, whatever. But most of the time, they're going to actually do a colonoscopy. I'm telling you, they're going to do a colonoscopy just to make sure that they're not missing some type of colon cancer. Okay? Now, if it is an external hemorrhoid, and we can see the hemorrhoid, and this patient's having the typical symptoms of anal itching, maybe they have blood, but we can see that the hemorrhoid's actually irritated, maybe has some bleeding going on, then we can treat these with high fiber foods to try to get them to have a bowel movement easily. Make sure they're hydrating well. We'll sometimes give stool softeners to kind of help that stool pass easily. You can give them topical creams like hydrocortisone, which kind of helps calm down the inflammation. Sits fast. Essentially, what that is a patient sits in they sit their bottom in a warm tub. That's all they do. You sit in a warm tub, and that helps kind of increase blood flow. It calms down inflammation, and so that's a very helps with spasms too. Sometimes you get spasms with these things, so it kind of helps calm down that area. And then sometimes they'll go and do surgery, especially if these hemorrhoids are persistent. I remember whenever I was doing my surgery rotation in phase 2, they did a hemorrhoidectomy. That thing looked rough. I don't know. If I had hemorrhoids, I would not do that. I would just kind of try to. That thing was terrible. It was bad. But sometimes they'll do that if it's really bad. But again, if somebody has painless rectal bleeding, you don't know what it is, don't assume it's hemorrhoids. Get them over to a GI doc so they can evaluate that. Go ahead. Patient history, what do you mean? Like,
So, recent pregnancy or something like that, where it would lead you to be that, hey, this is just normal.
if I can't see it, no. If I can't see it, no. I had a dude one time come in. He was 37 years old, and he came in and told me he had hemorrhoids, and he was having bleeding, rectal bleeding, right? And he told me that I forgot who, somebody in his family was a GI doc, and they told him he had hemorrhoids as well. And he had this his whole life, he told me. So I told him, I was like, okay, dude, well, we gotta check, gotta take a look and see. He was very resistant. He didn't want to. It's a private exam, right? And it's uncomfortable. So I was like, well, if I can't see and I can't verify that what you're telling me is just a hemorrhoid, then I don't know for sure, right? So I told him, I was like, if I can't see, I'm going to just refer you to GI. And now GIs hate that, right? They hate when you don't do an exam and then but you send them their way. But I can't do anything about it, right? So I sent him to GI. Guess what? They did a colonoscopy. Guess what? He had colon cancer. It was stage, I'm for real, it was stage 1, they were able to remove that mass, but that taught me, don't ever just assume it's hemorrhoids. Because this dude was 37 years old, he had colon cancer, which is super rare, like you don't think about that in a young person. But they were able to remove that mass, and he ended up living, right, thank God, but yeah, so you can't see it, just get more. All right, hemorrhoids, sorry I haven't you look at these pictures for too long. So this is what hemorrhoids look like. So small, right, asymptomatic. That one down below, this is a dilated thrombosed hemorrhoid, so it looks, looks angry, looks swollen. And then this prolapse, if I saw this prolapse, definitely they need to not be here. They need to go somewhere else. All right. So ischemic bowel disease. Ischemic bowel disease, we think about this in 2 different ways. We think about it in chronic and acute. So this is chronic, right? With ischemic bowel disease that's chronic, they have atherosclerosis. They have plaque buildup in their mesenteric arteries. And as a result, they have decreased blood flow to their intestines, right? This is typically in older folks because it takes time for that plaque to build up. But the problem with this is it's very similar to angina. Very similar to angina. When somebody eats, your intestines need more blood flow. They need more blood flow to kind of break down the food and help with digestion, right? When somebody has this atherosclerosis, and they have this plaque buildup in their mesenteric arteries, or their mesenteric arteries, and you eat, because you're not able to get that blood flow into the intestines like it should, because you have this buildup, these people are going to have this pain after they eat, because you don't have enough of the oxygen coming to the intestines to actually help with the digestion, to actually support those cells whose job it is to help break down that food or and absorb the nutrients. So these patients are going to have cramping. They're going to have cramping in their abdomen, typically about 30 minutes after they eat, and then it's going to go away after about 1 to 3 hours, right? So it's very similar to angina, like stable angina, right? These people are going to, every time they eat though, it hurts, so they're not going to want to eat. They're not going to want to eat, and so subconsciously they're going to reduce their meal intake because they associate pain with food, right? Or food with pain, however you want to say it. When they're not eating well, they're going to be losing weight. They're not eating, so they're going to start losing weight. We don't really do much for this. We don't do much for this except try to treat the comorbidities. Try to treat their hypertension. Make sure they're on statins to help reduce their plaque burden. We try to give them high-calorie foods with low volume. So we'll give them protein shakes or things that will kind of get in their system that are high-calorie without them having to eat so much food. But essentially, we're just kind of treating the comorbidities. We're not going in. We're not doing any type of breakup of the plaque or anything like that. We're just trying to manage the comorbidities. Now with acute ischemic bowel disease, this is dangerous. This is very, very dangerous. There's some type of clot that develops in the mesenteric artery, right? There's an acute thrombosis that blocks the blood flow. So with the chronic, right, you still have blood flow. It's just slow and low. With this one, there's an abrupt clot that develops, or a clot that can actually embolize to that region, and it cuts off blood flow completely. We think about this in our older folks as well, because with the mesenteric arteries that that feed our intestines, it's not just like you have one artery that just feeds one portion of the intestine. You have these collateral vessels as well. So just in case one gets blocked off, you have these other vessels that are still able to perfuse that intestine, right? When our older folks, if they have atherosclerosis, their collateral vessels are not working like they're supposed to. They're not nice and wide open. There's plaque buildup. So when the thrombosis forms in these, our collateral vessels are already not working like they're supposed to because of this plaque buildup. Now we cut off the blood supply, and now when we cut off this blood supply, that tissue is becoming necrotic. There's no blood flow going in there anymore. You have these collateral vessels, but they're not working right because there's too much plaque buildup. When that happens, and that those intestines start to become ischemic, they start to die off, right? So you worry about these intestines actually dying off and perforating when they rupture. Guess what? You got stool in there, and that stool is going to go to the peritoneum and cause peritonitis. You also worry about sepsis because you have bacteria in that stool, and it can actually go into our blood and cause a systemic infection sepsis, a septic infection. This is not associated with eating. So your patient is just sitting on the couch one day, watching TV, and then boom, they get this clot, right? It comes on suddenly. This pain is very severe as well. It's very severe. It says pain out of proportion here, right? So what this means is that you got this bowel that's dying, right? It's dying. It's very, very painful as that bowel starts to die, but there's no peritonitis quite yet. So you go and you do your exam, check your patient out, you listen to their belly, you push on their belly, and they look like they're dying. They're writhing in pain. When you go and press on their belly, it doesn't make it worse because that they're not having that parietal peritonitis quite yet. That outer wall is not inflamed. The intestines are dying, for sure, so that's painful. When you go push on their belly, you would expect them to jump off the exam table, right? These guys aren't doing that. Over time, as that thing starts to worsen, and you get the peritonitis, you get that spillage out into the peritoneum, that's whenever they're going to have this, that's where it's going to make sense, right? So it might be confusing at first when you see a patient and they're saying, oh, my pain's 10 out of 10, I can't take it. When you do your exam, it's like, I wouldn't expect that. I would expect you to, when I push on your stomach, you're going to jump off the table. That doesn't happen off the bat. As that bowel starts to die, if you do like a stool study, if you do what's called a Wyatt test, which looks for blood in stool, if it's not quite dead yet, that study is going to be normal. There's not going to be blood in stool. As it starts to die and as that bleeding starts to kind of seep into the intestines, later on it's going to be positive, right? So initially, you may have a negative Wyatt test, negative fecal occult test, but then later on it turns bloody because that bowel is actually dying. But it says down here, high index of suspicion. You have to really consider it. You have to consider it as a potential diagnosis. When your patients come in and they have severe bowel pain, especially if they're old. If they're really old, you got to think they probably have plaque buildup in their mesenteric arteries. And if you're not thinking about it right off the bat, you may miss it until it's too late and that bowel starts to really die off. Now, either way, when this bowel starts to die, we're going to send it to a surgeon, and that surgeon's going to take that dead portion of the bowel out. But what we want to try to avoid is that perforation, because when you get that peritonitis again, that's bad. You don't want that for your patient. So here's an example of kind of what that can look like. So you get these clots that develop, and then if you don't catch it in time, it starts to necrose, and then eventually starts to, again, pain out of proportion is typical with this. All right, so kind of, let's talk about the esophagus. So with esophageal cancer, right? Esophageal cancer. In the world, outside the United States, the most common type of esophageal cancer is squamous cell carcinoma. That's typically associated with the upper and middle esophagus. The reason behind that is I told you in your esophagus you have squamous cells, right? Their job is to kind of help protect our esophagus from what we eat. It's called very tough cells. Worldwide, if you've been out in the United States, a lot of people smoke. A lot of people love to smoke outside the U.S. People smoke here too, but not like outside the United States. And so tobacco, alcohol, hot fluids can actually damage damage the entire esophagus, but it can more so damage that upper and middle because that's where that stuff is eventually coming into, right? In the United States, the most common type of esophageal cancer is that lower esophageal cancer. And that's that precursor, that Barrett's esophagus that can turn into cancer, right? This is called adenocarcinoma. Adenocarcinoma, all that means is that you have cancer of cells that their job is to help secrete and absorb, right? So I told you with Barrett's esophagus, you get that metaplasia, you get that change from the squamous, right? When that change happens, these turn into those columnar cells, which are part of the cells that secrete and absorb, right? They're transforming into the cells that are normally in our gastro. The most common reason for this is chronic GERD. GERD is a very, very common thing. When you have Barrett's esophagus, that's like think of it as pre-cancer. If you don't treat that Barrett's esophagus, that transformation of those cells, and over time it's going to lead to esophageal cancer, and that's going to be typically in that lower GI tract or that lower esophagus, because that's where the acid's coming into. That's more common in the U.S. So U.S., Lower esophageal cancer is very, very common. Outside the U.S., it's typically that upper and middle cancer. Now, your patient's going to present with dysphagia. That means that they're having difficulty when they swallow. And it's not like achalasia. Remember we talked about achalasia where when they swallow foods and liquids, it's both of those are hard to swallow. Both of those are hard to swallow. With this one, because you have this mass, they can still swallow liquids initially. It's that food that they eat. When they're eating food, that feels like it's getting stuck. It feels like it's difficult to swallow. Over time, if that thing continues to develop, then it's going to be harder for that liquid to kind of go down the esophagus. But initially, it's solids, then liquids. You're going to have otonophagia. That means it's painful when you swallow. They have pain when they swallow. When you have a cancer in the esophagus, that thing can ulcerate. And as food tries to kind of get past that point, it's going to be very, very painful. These kinds of cancers oftentimes metastasize to the liver because the way especially the lower esophagus, the way those veins drain, they drain into the liver. And so if you have cancer cells in the esophagus and they get into the blood, and they go to our liver, they can set up shop there and cause all these liver cancer spots. The hard part about this is that we often don't find this soon, right? Because think about it. Your patient's coming in, they got chronic heartburn, they got chronic GERD. If they're not having any symptoms quite yet, or maybe they're having minimal symptoms, or you don't ask, which a lot of people don't ask for some reason, is you have pain with swallowing, is it difficult to swallow, you may not catch this. You would hope a patient would tell you this stuff, but you'd be surprised at stuff patients won't tell you. It's not that they're not thinking about it, it's just that they don't think it's an important issue. Maybe it's been ongoing for so long that they just got used to it. You have to ask those questions, especially when somebody has GERD. Does it hurt when you swallow food? Do you feel like food gets stuck? Do you feel like liquids get stuck when you swallow? If you don't catch this in time, which is often the case, it will metastasize, and these patients, once that does, it's very, very hard to treat that. All right, so gastrocarcinoma, this is cancer of the stomach, right? 95% of these are those adenocarcinomas, right? That makes sense. We have those columnar cells there, and so if there's cancer of those cells, they're going to be this type of cancer. The other 5% is typically due to lymphoma. We got lymph cells there as well, so we can get lymphoma. Don't worry about that. Most of the time, this is going to be just cancer of those cells that are in the stomach. Most commonly, we associate this with H. pylori. This is what I was telling you. If you have a patient with H. pylori and you treat them, you have to make sure that you eradicated that pathogen. If you did it and that thing is still there, that pathogen causes chronic inflammation, which can lead to development of cancer. Tobacco and alcohol, again, it's a common theme here. It's very, very bad for you. That can contribute to development of cancer as well. Most of the time, we find this whenever we're doing some type of workup. We do an EGD. They're going to go, they're going to look at the stomach, just kind of see what's going on there. We may think they have an ulcer or they just have chronic heartburn and they haven't been evaluated. We go, or the GI doc goes, does a biopsy of that mucosa of the gastrum and then finds this gastric cancer. But this is very hard to tell whether a patient has this or not, right? They're going to have epigastric pain, very similar to gastritis. They may have dyspepsia, they're not going to want to eat, right? Very similar to somebody who has this chronic gastritis. They may have blood in their stool, or they may be vomiting blood. Now, somebody has blood in their stool or they're vomiting blood, they're going straight to GI. But they may not have this right off the bat, right? These two other things, Virchow's node and Sister Mary Joseph nodule. So with the Virchow's node, this is left supraclavicular lymphadenopathy, right? Only on the left side. It has to do with the way the lymph kind of drains eventually up into that thoracic duct. But that's why when you guys check lymph nodes, especially the supraclavicular, anybody who has supraclavicular lymphadenopathy, that is not good. Those things should not be inflamed. Up here in the neck, okay, whatever. It's still not good potentially depending on what's going on. But anything up here in the supraclavicular, not good. Typically associated with some type of cancer. And so when you guys check this in physical exam in real life, don't do it over the shirt. Because if it's real small, you may miss it. You gotta move that shirt down and try to fill in there. That Sister Mary Joseph nodule, when I was here, there was a guy who taught this, not this class, but another in GI, he taught this. He told us that if somebody has a Sister Mary Joseph nodule, that means that you got to pray to Sister Mary Joseph because you're probably going to die, right? That's not the case. I believe it. I was like, oh, okay. That's not the case. I looked this up actually, because I was like, why do they call it this? I guess back in the day, there was this nun who was helping some surgeon or something like that, and she found that people, when they had some type of abdominal cancer, she saw that there was a common theme that they had this nodule at their umbilicus, so they named it after her. So, but either way though, if you have any of these, what this nodule is that cancer can actually metastasize, go through the peritoneum, and then start to cause cancer of the belly button, essentially, right? That's what this is. It's a cancer of the belly button. If you have these, that typically means that there's some type of metastasis going on. This is not specific though for gastric cancer. Any type of cancer in the abdomen, so pancreatic cancer, ovarian cancer, anything in the abdomen can cause either of these. But we mostly associate it with gastric cancer. Same thing, very hard to, if we identify it early on, we can try to treat this, but if not, then we do worry about metastasis and death. Go ahead.
Would you see
What's that?
Did you also see
Yeah, anything in the abdomen, yeah. Most of the time, gastric, very common to be associated with gastric, but really anything in the abdomen can cause that. All right, almost there. All right, colon cancer. So colon cancer, I don't know if you guys have been tracking or worked in clinics. We used to try to identify. We used to do colonoscopies at 50 years old, right? That was the standard therapy. Because there's so much colon cancer not going around, but there's an increasing incidence, especially in our younger folks, right? I told you that I had a 37-year-old dude with colon cancer. They dropped that recommendation from doing colonoscopy from 50 to 45, right? And will it change in the future? Probably, I don't know. But the older a patient gets, the more that risk increases, right? Most of the time, these are from sporadic mutations, like there's no family history of this, but sometimes there is a family history. There are certain genetic conditions that make people more prone to this. You'll learn about that in GI. But if you have irritable bowel disease, if you're a cigarette smoker, if you eat a lot of processed meats, anything that causes chronic inflammation in that colon can cause those cells that are often replicating, right? The mucosa in our colon is replicating or replenishing every 3 to 5 days, right? The longer you expose that stuff to any type of inflammation or some type of carcinogen, the greater risk you are for developing a mutation and causing a cancer of the colon. So colon polyps, right? Colonic polyps. Talking about polyps. These colonic polyps, all they are is just a growth of colonic mucosa, right? They're just growth mucosa. They can be normal, they can be benign, they happen normally, but sometimes these polyps can be precancerous. And if we don't catch those precancerous ones, we don't remove them, they can turn into cancer. So oftentimes when they do a colonoscopy, if they see any type of polyp, no matter what it looks like, they're going to remove that thing because these polyps are what transform into cancer. So if we don't remove it, we just leave it there, then this patient, if it's precancerous, they're eventually going to develop cancer. So we remove all polyps, no matter what they look like. A lot of patients may not know they have colon cancer until they start having bleeding, right? They have that bleeding. It may be bright red blood, but it may be so small that you can't see it. Maybe they're bleeding just a little bit. So one of the ways we try to identify this, especially if we think cancer is going on, is we'll do a cold study to see if we can identify blood in the stool. They may have abdominal pain depending on where it's at. If it's if you have a tumor in your right side of your colon, that could cause obstruction versus the left side. That can cause something called it can cause very thin stools. Think about it, you have a mass in your colon, and that thing is growing, and it's getting smaller, right? Because that mass is growing and it's kind of pushing on that lumen. That stool starts to pass through that portion. It may get obstructed, or it may just get pushed in with force. That on the other end, that stool is now pencil thin. So somebody comes in and they tell you they have a very thin looking stool. That's not normal. Normally stools are not pencil thin. So if they're very, very thin, that may mean they have a mass in there that's growing slowly around that lumen. And what can get through is only a small amount of stool, which makes that stool thin. They may have bright red blood, depending on how much blood is actually is occurring. Weight loss. We talked about cancer and weight loss. If you have cancer cells, that's going to definitely increase that. Those cancer cells like to take all that nutrients, and so patients are going to start losing weight. And then these bowel changes. Again, if you have a blockage there, or if you have inflammation there, patient's going to have diarrhea, constipation. One of the things you want to do is ask your patient, how are your bowel habits? Have they changed at all? If so, describe to me how they've changed. Don't just ask, have you had any changes in your bowel habits? Like, tell me, did you go every day? Now you're going once every 5 days. Did your stool change from well formed to watery? You got to get the details. But again, the way we identify this, the best way to identify this is with colonoscopy. You got to send your patient for a colonoscopy. We will just send them once they turn 45 years old. We're going to send them for a colonoscopy, no matter their family history. If we think they have colon cancer, though, we're going to get them to a GI doc right away to do that colonoscopy. Has anybody had a colonoscopy before? You got to admit it. I did. It was interesting. It wasn't terrible. It wasn't terrible. It wasn't terrible. But it was interesting. All right. So that's what a colonoscopy looks like. They just stick a camera up there, look for polyps. They see one, they take that thing out, and then you pray that it's normal. And most of the time, not most of the time, sometimes it is, sometimes it's not. But if we get rid of that polyp, if we completely get rid of it, our patient's good. They'll probably have sooner colonoscopies. Normally, we'll wait every 10 years. That's normal. Most of the time, they'll do it every 3 to 5 years, depending on what the polyp looks like. All right, that's it. Questions for me? Yeah. You're kind of sedated. You're kind of sedated.
Stand still.
I remember looking at the monitor and then kind of being awake, and then I was done. So I don't know. You're not intubated or anything. You're sedated. You don't remember it. So that's the good part. Cool. All right.